This
Hey friends,
conference will
Joe
now be
DeMattos
recorded.
here at HFAM. Welcome today for our conversation with Gene Ransom, the President and CEO of MedChi, the Maryland State Medical Society. We'll get into that in a minute. I wanted to let everybody know that this webinar will be available to HFAM members, so it is being recorded. Wanted to let you know that and to introduce Patty and Hope on the team. Patty, some housekeeping, and then I'll mention Hope and what she's doing.
Hi, yes. Good morning, everyone, and welcome to our Maryland Total Cost of Care Contract call with Joe DeMattos and Gene Ransom. For housekeeping today, for those that all lines are being muted, whether you're participating via your audio on your computer or via your phone. We have muted all the lines. For those participating by their computer, throughout the presentation and discussion, you will be able to enter questions in the chat box, which you will find down on the right-hand side of your computer screen. And that works just like any other regular webinar that you may be participating in and want to ask questions. For those of you participating by phone only, at the end of the conversation, we will unmute the lines and open it for questions if there are any questions. Just please keep in mind, though, if you aren't asking questions, to keep your cell phone on mute so that there is no interference or disturbance from the outside. With that, I'd like to turn it over to Joe DeMattos and Gene Ransom.
Gene, can you hear me? We'll wait, make sure Gene can hear me.
Oh, no, I can hear you. I'm sorry. I put my thing on mute, so I can hear you just fine.
Got it. Well, Gene, listen, thank you so much for making the time for what I hope will be an informative but very informal conversation on the total cost of care. I'd just like to share a little bit about your background with our listeners today, because I'm not sure all of them realize that you were the youngest county commissioner, healthcare commissioner elected in Queen Anne's County's history. Is that true?
Yeah, I was elected as a county commissioner when I was 30, which is the youngest anyone's ever been to hold that post, and I served 2 terms. Now, that was a while ago, so I'm not young anymore, but I did serve from 2002 to 2010.
Well, you're young at heart, and we could hook you up with post-acute rehab care when you're ready. You know some people, so we'll get you hooked up.
Well, that's good to know.
Hey, and MedChi was really founded in 1799?
Yeah, we are the 7th oldest medical society in the United States. Interestingly, New Jersey is the oldest. We also had a really important role in the founding of both the University of Maryland medical system and in Johns Hopkins, and we really were the first kind of licensing entity. Originally in 1799, we decided whether or not you could practice medicine. Over time, obviously, the state took that responsibility away from us, and now we're more the trade association or professional association, for lack of a better term, for physicians.
And how many physician members do you own and represent, and how are they aligned professionally?
Well, we don't own any of them, but we have over 8,000 members. We're the largest physician organization in Maryland. Our membership is almost twice that of the AMA. We are the component of the American Medical Association, the AMA, but you don't have to be a member then to be a member of us. We say we represent all physicians, and we try to. We do our best to represent everybody, whether they're a member or not. We see that as our role, to be the foremost advocate for physicians, patients, and the public health of Maryland.
And you mentioned the National Association. I know we started this talking about how you began your career in Queen Anne's County as an elected official, but aren't you also an officer in the national organization in physician representation?
Yeah, I hold a couple different positions there. I'm currently on their Scope of Practice Executive Committee, and I just got put on the American Medical Association's Advocacy Resource Center Executive Board. So I've worked closely with the AMA over the years and have held different kind of staff level positions in that organization as well.
Well, you and I have been blessed to work with one another. As you may recall, I've been at HFAM for 9 years now, but I was the state director for AARP in Maryland for 5 years prior to that. And it was in that transition period that you and I first became aware and started working with one another pre-HFAM sort of straddling that transition I made from AARP to HFAM. And, of course, we've been seeing a lot of each other as Maryland has modernized and moved from what was a waiver included in the Social Security Act and what is now the contract and the total cost of care. So we've been working on this a while, you and I.
Yeah, and actually over the last 3 or 4 years, I'd say that the Health Facilities Association of Maryland and the facilities, long-term care generally, and MedChi have been more aligned than ever because our interests are very much at somewhat a competition with some of the interests of the hospitals at times, and we're in a similar position where we have to work with them, but we need to make sure that we're protected as we move forward under this new waiver. So we've been working very closely over the last few years and very much aligned.
No, I appreciate that. And my prediction is that we're going to get more aligned as time goes on. And as we sort of get to the middle and the end part of this conversation, I want to call out now that we'll more explicitly talk about what population health and the role physicians play and organizations that have physician practices play, what role they play going forward as we've now evolved the total cost of care contract to be more system-wide and more focused on population health. But for those of us on the line, you know, my members hear from me all the time. Why don't you walk us through, if you will, an evolution of the contract for those listening, and then I'll chime in where needed.
Okay. Well, so to begin, essentially, as you already mentioned, the waiver used to be in statute as part of the Social Security Act. In 2014, after about 5 years of negotiation, the prior administration moved it outside of the Social Security Act and moved it out of the waiver process and changed it into a contract. And that was when hospitals were really moved to global budgets and that new model. So every hospital starting in 2014 went to a global budget, and the entire system for hospitals only went onto a global budget. That process lasted for the last 5 years. And starting in 2019, we're going to be transitioning into what was just approved by the federal government and the Hogan administration, I guess a month or so ago, which they're calling the enhanced model, which is a new contract, which continues to keep the hospitals on global budgets and keep a cap on all hospital payments, but begins to start to measure the total cost of care and hold the hospitals accountable for total cost of care moving forward. So one of the interesting things when I think about long-term care and physicians is we are still being paid on fee-for-service basis generally. Most of our payment models are for what we produce and what we do, whereas now the hospitals in Maryland are entering into a 6th year where they are on global budgets, and they're now being tested on the cost of everything. So that creates some economic tension between the long-term care industry and the physician industry and the hospitals, because their focus is keeping costs down and total cost of care, and they make more money when less is done. And obviously, many of our payment models are still on a fee-for-service basis.
Right. So, so the traditional danger in that is that you have a system that's viewed, a non-traditional new system where a big part of it is not fee-for-service. It's total payment with a annual growth rate that's set at 3.58% and an incentive and a demand to save hundreds of millions of dollars over a period of years. So you have this system where part of it, a big part of it, the biggest part of it, is capped and the rate of growth is capped. And then you have partners in which, as you say, they're still mostly charging their services for fee-for-service. So the danger in that, where you have a new model that's not in alignment, is that there is top-down pressure, supplier to vendor pressure to reduce length of stay or to sort of change treatment models, downstream. And of course, the potential promise of that is eliminating the stream, is somehow, flattening the system, post-acute and long-term care providers working together, where there is no upstream, there's no downstream, there's one stream, and they aren't vendors and suppliers, but they're partners with vested interest and payment alignment, right? So that's the potential upside and the potential downside. Would you agree?
Yeah, I would, and I think the contract contemplates this tension, and what it does is it creates an avenue for gain sharing and care realignment programs between long-term care and physicians and hospitals. The problem is, though, is that you can create this artificial care redesign situation, but economic incentives do tend to win out. So it'll be interesting to see as we move forward. And I think one of the things we want to talk about, because I think some of the opportunities as these programs get created are real for both your members and mine, but I think it'll be interesting to see what wins, the economic incentives of how we're paid or these care redesign programs that are being created under the contract.
Well, I mean, I think ultimately there isn't a healthcare win or a financial win unless you look at clinical outcomes and cost savings as two sides to one coin. But in other parts around the country, the way that's worked is on length of stay pressure or cost of procedure pressure from the non-hospital providers, right? So that's traditionally how that works. Now, one thing that I think we should explicitly call out, and then let's talk a little bit about what you just teed up, is one big thing that happened from when we moved from the waiver to the contract, and now the second version of the contract, was the national doc fix. So the national doc fix was not in alignment with our contract, right?
Right. So that's been a major issue for MedChi and for physicians, and frankly, for your members who employ or contract with a large number of physicians in their facilities. Essentially, when the doc fix happened, which was wonderful because we don't have to go and fight to get our Medicare rate straightened out. And for those of you who, I'm sure you all know what it is, but essentially there used to be automatic cuts. They called the SGR cuts that would happen every year, and all the doctors would go to Washington to get it readjusted, and it never happened. Well, when they fixed that, when they passed the legislation to fix the Medicare cut, what happened was the Congress, in order to say that it wasn't going to cost as much as it did, created something called MACRA, which is the Medicare Access Chip Reauthorization Act. But essentially what it did was it started to incentivize physicians a little more on value. The problem is that the waiver was completed, or the first contract was completed before pre-MACRA, and it didn't contemplate it. So a lot of my physicians, your physicians, were not able to meet the MACRA goals easily because some of the care redesign programs that are happening in other states are not happening here. One of the things that we worked very hard.
So there was only downside. Go ahead.
Right. One of the things we did in this current new contract that just was approved by Governor Hogan a few weeks ago was create some opportunities for us on that. And I think there are really 4 big opportunities under the waiver that are really important for your members to understand. The hospital bundled program, the community, the CCIP program, the primary care program, and then the BPCI program that's being created Maryland specific. And I think those are 4 things that are going to be really important for them to look at and understand and know where they are in the process and what's happening.
Right. So those are basically primary care and bundled care initiatives that will allow hospitals, post-acute providers, and physicians to partner to make a promise to achieve better clinical outcomes and then share in the savings, right?
Right. And I think each one of them are kind of in different places in the approval process. And maybe if you don't mind, I'll just go through each one of them real quick because it might be helpful for your.
Great.
All right. So the hospital program, I'm not going to spend a lot of time on because I think most of your members, from a practical point of view, unless they're in a partnership with a hospice program or something like that, probably aren't going to be able to take advantage of that. But essentially what it really does is it allows hospitals who've chosen to participate to work with physicians around bundled episodes in the hospital setting. The second program, the CCIP, actually some of your members have started to take advantage of, and I know that at least one with St. Agnes is in place, and they're working on it with possibly doing it with Doctors Hospital as well. Essentially what that does is it allows community physicians to enter into partnerships with hospitals. That program is MACRA compliant, so you get your bonus payments under MACRA if you do it, if you hit the thresholds, and the hospital is able to pay gain sharing payments for the physician fees around a long-term care episode. Here's the problem with it. The problem is that it requires a hospital to agree and participate with you. And the issue is that hospitals are not really incentivized to do a lot of these, and only where there's other economic conditions do you normally have participation. Frankly, the two hospitals that are, one that is doing it and one that's considering doing it with nursing homes, in both cases, we're talking about a very small number of physicians and a very small number of patients. So while it's an interesting opportunity and worth learning about for your members in case maybe you want to do something unique or different through it, it hasn't been the home run. The biggest opportunity, and the one that I think your members need to really pay attention to, and if there's one thing they hear from me today, it's this, is that the doctors who are working in nursing homes who are geriatric physicians are eligible for the primary care program. You do not have to have a hospital partner. You can sign up directly for the program, and as long as you meet the requirements, you're eligible to do it, and you can make extra money, care management dollars, on top of your regular fee-for-service payments for those Medicare patients, for all your Medicare patients. And you have to sign up for this program by August 31st, which means you have 9 days to sign up and fill the form out online. It's not complicated. We might want to spend a little more time going through the primary care program because it's also a MACRA program. So it could be a really big benefit the way this got created as part of the new waiver, because you're not required to have a hospital partner. You can make a decision to sign up on your own. You get paid care management fees for your Medicare patients. The doctor has to have 125 Medicare patients to be eligible, but they will get paid care management fees on top of their fee-for-service for every one of those patients. And this is a MACRA compliant program, so starting in 2020, you'll get the 5-point bonus on your Medicare payments under MACRA. So it's a pretty good deal for primary.
That's why we scheduled this call now, my friend. Yeah.
Well, I would suggest, and I know that some of your members, because we've actually been in communication with some of your members, I know some of them are looking at doing it, but a lot of them aren't aware that geriatric physicians were included in the primary care program. It says primary care program. It doesn't say primary and geriatric care. So they just probably didn't realize that that was something that was eligible for them, but it's really something they need to look at.
Yeah,
the last program that hasn't been approved yet, but is in process, and something that you and I have been fighting for, is the BPCI program. A lot of your members in other states are taking advantage of this program, working with the federal government on BPCI, which is a bundle payment program federally that's MACRA compliant. It has not been implemented in Maryland, and it's something that you and your members and I have brought up repeatedly to the state that they need to fix this, because it's a voluntary bundle payment program where you can be MACRA compliant. The plan on that is we are creating a Maryland pathway to have BPCI, and that's in development. So I don't think there's a lot that anybody needs to worry about urgently on that one. I think, again, the hospital care improvement program, or that bundle payment program, probably doesn't help your members too much. So the two they need to think about are the CCIP and the primary care. And the primary care, they really should look at today.
Right. I agreed. And, thank you for mentioning on the call that you and I have been very much fighting for the BPCI. I always have trouble with that acronym, Gene.
Yeah, it does. It bothers me too.
Yeah, but we've been advocating for it. And, I look forward to we partnering with you going forward on setting up that Maryland pathway.
Yeah, we just had a question from the audience about how would I have my medical director sign up for the Maryland primary care program. Anybody who wants to can call MedChi and just call the main number 410-539-0872 and hit 0 and ask for Amalia or Colleen George. Or you can go to our website, and I can maybe send you a link to the page, which has information on how to sign up for it. But there's a portal online on the health department that shows you all the information. But we have 3 staff people at MedChi who are helping any physician who wants to sign up MedChi lobbied very hard, as you know, to get the primary care program approved as part of the waiver. It represents a significant amount of new dollars to physicians and to long-term care as well. And I do know for a fact that at least 2 of your members are currently in the application process. So I think it's going to be a nice new payment amount, and it financially incentivizes us to manage population health differently. So we've been really trying to get as many of our members to sign up as possible for that program.
Right. We'll get a link from you, and we'll send that link to all of our members today on how they can sign up, as well as getting word out on how they can reach out to you in the next 5 or 6 days to get your help. And we really appreciate it. Lunch is on us. We'll have to. Who are your staff members that are working on this?
Amalia and Colleen George.
We're gonna have to send them over some crab cakes if they eat them.
Well, this was, one of the issues with the waiver has always been, from a MedChi point of view, and maybe this is true in long-term care as well, is the hospitals have benefited greatly from the waiver. A lot of extra money comes into Maryland, but all that money goes to the hospitals. So for the first time in this new contract, there was this language that allowed us to actually benefit a little bit. So what I really don't want to have happen is to create this opportunity, and then my members and even my non-members, but my physicians, don't sign up for it, and we don't get the extra money that comes in, or some portion of it. And that was something that I think is really important. All the investment should not just be in hospitals in Maryland. It needs to be in the other parts of healthcare that help make people better.
Well, I agree. You and I have been in those meetings over the last two or 3 years, right? And so the total cost of care contract doesn't work on the one hand unless hospitals have a resource for non-hospital care, high acuity non-hospital care, post-acute long-term care, and population health doesn't work without deeper, more meaningful, coordinated touches by physicians. And I think what's one of the things that's surprised me about our meetings is that a lot of folks don't realize that my members employ physicians. They're still under the impression that skilled nursing and rehab centers, either on the post-acute side or the long-term care side, aren't employers of physicians, and it's just not the case anymore. So again, the total cost of care contract, just straight up going forward, it doesn't work unless you have a safety valve in post-acute long-term care on the one side, again, doctors being critical to that, and on the primary care side, so much of what happens in healthcare and keeping people healthy happens outside of hospitals under the care of physicians. And so it doesn't work unless you do that either.
Right. So we're really excited about the opportunity. As of yesterday, when I spoke with Dr. Haft, who's the Deputy Secretary of Health, he said that about 150 practices had at least started the application online. And again, the application has to be completed by August 31st. CMS is not going to give any extensions. If you miss the August 31st deadline, you will not be able to sign up again until next year. Now, for some areas, maybe some of your members do not have enough Medicare members that are going to be assigned to them to hit threshold, but it's definitely worth at least looking into and having a discussion. The application is not something that you should wait until August 31st, which is the Friday before Labor Day, to fill out, because you do need to have some letters. You have to have a letter from your owner, a letter from Chris saying you're connected, which almost all of your members are, and a letter from the practitioner. So, getting the stuff together can take a little bit of time, but it's nothing that's burdensome. And again, our staff is willing to help anybody who wants help signing up.
Well, no, we really appreciate it. So what keeps you up at night about the evolution of the total cost of care contract?
I think the biggest concern I have is, and I've been now doing healthcare stuff. I was a healthcare lawyer before I became the CEO here. I think my biggest concern is I remember when I first started kind of working on these issues, there were things where the HMOs who were capitated, would do things like throw women out of a hospital after they had a baby without giving them enough time, and they would create all kinds of strange rules to deny care. And I'm a little worried that the model that's been created has some similarities to those HMO capitations. And I worry a little bit about how do we protect patients. And I think ironically, you and your members and MedChi and my members are going to play a really important role again, like we did at that period of time when we would fight with HMOs, where we might have to have a discussion with some of these large systems about how care is delivered and who does it. Because again, their economic incentive is to provide less. And when you create an economic incentive like that, bad things can happen.
Yeah, agreed. You know, you and I were both quoted after the new contract was signed in the media, and you know, I said what I worry about is downward pressure that withholds necessary care. You know, downward economic pressure that then results in less access to quality care. So we agree on that front. But I think we've got the potential to get it right in Maryland with this contract.
No, I think we definitely do.
So let's open it up here and let's explicitly ask people online first if they want to type in any questions. I know we had that one earlier, but are there any other questions for those of you that are on computers that want to enter a question? And again, we'll send the link out. We'll send the link out to all of our members with regard to sign up for the primary care physician program. But let me just pause here and see if any questions come in, and if not, I'll ask Hope to unmute the line, and then we will see if there's any audio questions. All right, Hope, will you unmute the line, and let's see if there's any folks that are calling in but not on computer that want to ask a question. Are they unmuted now? So friends, everybody's unmuted. Any questions that you'd like to ask about what Jean and I have covered today? And by the way, some of you are self-muted. We've unmuted all the folks in the system, but some of you may be self-muted. So if you're self-muted and you want to ask a question, now would be the time. It's so neat when you unmute, you get all the background noise.
Yeah, I just sent you 3 documents, and I CC'd Colleen and Amelia. Feel free to send out their email addresses as well to your members. Again, I think the biggest takeaway from today is, since you have such a short deadline within 9 days, is to just make sure your members look at that information and see if it's something they want to take advantage of. And for some of your members who don't employ but contract, they should talk with their contract partners because, frankly, there might be a role for them to partner with those contract physicians to maybe provide some of the care management services that are required under the primary care program. So I still think there's opportunities, and some of those groups might not be aware of how lucrative this could be.
Absolutely. Absolutely. What I love about it, by the way, this program, the primary care physician program that we're talking about so much today, is I love that it aligns care management with financial incentives. You know, people are actually getting paid to do what they really want to do in the first place, which is achieve better health care outcomes and coordinate care in their setting rather than somebody else forcing that upon them. All right, I don't see any questions, Jean. So in the interest of time, what are the things that you think we haven't covered today that are a must for both your and my members to track on in the evolution of care related to the total cost of care or just in general here in Maryland?
I think the biggest issue that we kind of have outstanding are the next steps on the implementation. I think the pressure on both of our organizations and our members from the hospital industry is going to be great because they're feeling the pressure. They're essentially under 2 global budgets, one for the entire state and one for each one of their hospitals. And they're going to try to figure out ways to do more with less so they can continue to have reasonable profits. And that's going to put a lot of pressure on us. I also think you and I both serve on the Health Secretary's Vision Committee, and you and I both serve on the Stakeholder Innovation Group, where we're going to be working on new bundle payment programs and new opportunities. And I think our organizations are going to want to stay close, and we're going to want to hear from my members and your members about where they think there could be opportunities that we should push for, because unlike the rest of the country who are going to be going through CMS, a lot of our changes are going to be able to be done on a state level, which creates both an opportunity and a threat. The opportunity is maybe we can do things a little differently that help us. The threat is that there might be programs that we want to take advantage of in other places that don't get implemented here. So those are the big issues and kind of the next steps that I'm thinking about around the waiver and the total cost of care contract. And again, I would just suggest that the big takeaways for your members would be the primary care program, see if it makes sense for them. The deadline is August 31st. At least understand and look into what's going on with the two current care redesign or gain sharing programs, the hospital program and the CCIP, the community program that some of your members have taken advantage of. And last but not least, to keep a corner of their eye on that new bundle payment program as it comes down the pike.
Yeah, I think so too. It's going to be interesting to see, the bundle payment program initiated by hospitals initially, is voluntary. So it's going to be really interesting to see how many hospitals ultimately, want to enter into bundle payment agreements and on what critical areas of care they focus. And of course, you've heard us advocate for years for this, and there's a framework for it in the waiver, and that's of course to have down the road to have post-acute providers actually be the conveners themselves of these bundled programs.
Yeah, I think they should be able to be conveners. I think physicians should be able to be conveners. I think the state should be able to be a convener. I think we want to create multiple opportunities. Everything doesn't have to be controlled by a hospital necessarily. It's not. It doesn't make sense. It's not the way things work. So I think that's something that we're both going to have to fight for. I think the other thing too that we need to worry about is the hospitals maybe pitting our members against each other, maybe taking a large physician group and saying, we're not going to sign a bundle payment agreement with you. We're going to do it with our employed physicians instead. And that could create tensions in my membership. And I could see similar scenarios in yours, although because of the cost of getting into your market and the way it works, it might not be quite as bad, but it's still a real possibility. And that's something else I think we're going to have to think about going forward is how do we protect everyone being treated fairly in the system.
I agree. I think one of our strengths in the work that we've done together over the last few years is the fact that we really have been more aligned than not, and we haven't let people divide us. So to the extent that we can have the discipline to continue that, I think it not only will serve our members well, physicians, post-acute long-term care providers, and physicians working in our setting, but also, the 800,000 Maryland Medicare beneficiaries that they serve. So one of our keys is going to have to continue to be the focus and unity and actually doing more together, not less. Would you agree?
100%. And to that end, I've sent you the 3 documents that you can share with everybody on the call. Again, please feel free to share my email address and Amalia and Colleen as well. And we're more than happy to help any of your members who want to sign up for that Maryland primary care program.
Well, Gene, I got to tell you, this has been a fantastic use of the last 45 minutes and cannot thank you enough for our partnership in the meetings, for the guidance that you provided me privately, for all that you do. And, again, I'm cautiously optimistic about the future. And one of the reasons that I am so optimistic is the fact that we have so much in alignment, our 2 associations, and we have the potential to make such a difference in aligning clinical outcomes and cost savings for improving the lives of Marylanders in need. And that's what gets me to come to work every day. So I appreciate your friendship, your partnership, and the fact that you made the time today. You've been a tremendous resource to our members. Thank you.
And thank you. I really appreciate our great working relationship, and I really appreciate the fact that HFAM and MedChi have been working so closely together on trying to make sure this thing gets done right.
Thanks, brother. I'll see you soon, and we'll get this all out to our members today.
Great.
Be well. Thank you, everyone, for joining us. Again, this has been a conversation between me, Joe DeMattos, the President and CEO of HFAM, and Gene Ransom, the CEO of MedChi, the Maryland Medical Society. We have recorded this conversation. We'll make it available to members, and we will, in fact, get those resources out to our members today on how to sign up for the primary care program as part of the total cost of care waiver. Thanks, everybody. See you soon.